Well, good morning, everyone. I'd like to welcome you all to today's public presentation on Maine Certified Community Behavioral Health Clinic rate reform methodology. I'd like to ask everyone to leave questions in the Q&A function throughout the webinar. Our team and the Maine Care team will be reviewing those questions throughout the webinar, and we also have held some space at the end of today's call to talk through those questions live, as well as some other questions that may have come up throughout the call. So we'll be checking that Q&A throughout, but also circle back at the end. One thing I would like to note, and something that we'll also follow up on at the end of the call, is that we will have an opportunity for written and official comments to be submitted to the state. So I'll get into the details of how to submit an official public comment at the end of today's call. But I would like to note that comments in the chat function during today's call are not official comments unless submitted in writing to the state mailbox. So we'll circle back to that at the end. But if you have a question in the Q&A that you'd like to also submit as a written comment, we'll walk through how to do that. All right. So getting into today's agenda, the couple things we're going to talk through are Maine's Certified Community Behavioral Health Clinic Initiative, the CCBHC prospective payment system rate background, how the CCBHC PPS rates are developed, and the Maine Care team's development process. And then we'll cover those questions at the end. One thing I realized we should have done on the prior slide is do some introductions, so I'll introduce myself quickly. I'm Toby Ramsdell from Mercer. I lead the CCBHC financial team at Mercer. I'm a CPA, and we've been working with the Maine Care team for the last 2 years on development of the CCBHC model and the PPS rates in the state. All right, a couple acronyms I'd just like to call out is we'll be referring to the Certified Community Behavioral Health Clinics as CCBHCs. The prospective payment system will be referred to as the PPS or PPS rates. And you may hear us refer to the CCBHC demonstration, which is the federal CCBHC model, as the demo. So those are a couple of things that you might hear, and I want to make you all aware of so that those don't raise any questions. At this point, I'll turn it over to our Maine Care partners to talk through Maine's CCBHC initiative.
Great, thanks, Toby. Hi, everybody. I'm Liz Romillard. I'm the Certified Community Behavioral Health Clinic Program Lead. I work for the Office of Maine Care Service as a part of the Delivery System Reform Unit. I want to give a brief overview of what the CCBHC initiative is for those that are joining this call new to the initiative. The CCBHC initiative started back in 2015 through a federal appropriations to launch a demonstration in 10 states. SAMHSA, the Substance Abuse and Mental Health Services Administration, and the Centers for Medicare and Medicaid Services, so CMS, jointly put out a call for proposals to launch the CCBHC initiative. And so 10 initial states started to test this new model. And over time, since that time, that first initial launch, there have been several grant opportunities for specific organizations and clinics to test and launch the CCBHC model. And then Maine recently had an opportunity to also enter into this demonstration program. And so as a state, we are now part of this demonstration program and will be a part of this through 2028. We can go to the next slide and I'll talk a little bit about what this model is. So CCBHC is an integrated mental health and substance use care model. It brings together services that have been traditionally covered and paid for through fee-for-service under a value-based care and payment model for those service delivery. Maine has been implementing and planning for the implementation of CCBHC since 2021 and has been working on that design up until this last year when we were entered into the demonstration or accepted into the demonstration. Over this last year, we've been putting the pieces together for the final implementation of CCBHC with a goal launching over the next several months. CCBHC has 6 core components to the model itself. There are staffing requirements, accessibility requirements. CCBHCs must offer care coordination as an activity or a foundational service that is offered to anybody. It's not actually a service that's paid for, but instead, as I had said before, an activity that's offered to individuals. There are services that are required to be offered within the CCBHC, and there are 9 core services that these services are covered under. And then there are also quality and reporting requirements of the CCBHCs. There are 25 measures, standard national measures that the providers who enter in and become CCBHCs must report on and provide a review and quality improvement on those measures. And then lastly, CCBHCs must have governance standards. And at this point in Maine, we expect 51% of the governance board of a CCBHC to include representatives of people with lived experience. We can go to the next slide. I'm not going to read this slide, but I think it is important to understand what services we're talking about when we are reviewing the rate methodology for CCBHC. So there, as I had mentioned, 9 core services that are required of CCBHCs in Maine and across the country. And these are the services that we've outlined as the services. So the top bucket is the required set of services. And then in addition to those required services, CCBHCs are required to serve their communities and provide community needs assessments to perform community needs assessments to understand what those needs are, and may offer state-approved allowable services to individuals in their community, which you can see this list here. Go to the next slide. Great. So to become a CCBHC, there is actually a requirement to go through a certification process with the state. This is a requirement from the federal government that the state Department of Health and Human Services implements a process to review clinic readiness and the implementation of CCBHC through a rigorous process and approve them. The certification process must happen on a frequency of every 3 years as a part of the CCBHC demonstration. You can see here that there are some key steps that are a part of this. First being a programmatic review of the organizations. So if you've been following along with the state process this last year, we've opened the applications and certification periods for an initial cohort of CCBHCs. Those organizations have provided a copious amount of information so that the department could review and programmatically certify them as CCBHCs. And now we're into this next step and next phase of cost reporting and finalizing the cost reports based on the approved programmatic certification for the CCBHCs. And today we will be reviewing is the methodology applied to the cost reports for CCBHC to finalize and finalize the certification for the CCBHC, the initial cohort of CCBHCs. This process will happen every 3 years. So as we go through and implement CCBHC, there will be a 3-year cadence of going through this process. Go ahead, Toby, next slide. Great, I'm gonna pass it over to my partner, Jessica, who will talk about the purpose of this meeting and our rate reform, rate determination processes.
Liz. Hi, everyone. I'm Jessica Levesque, a project manager in the rate setting team, part of Office of Maine Care Services. I'm here to talk about the rate determination process that we have. This process or this law is a standalone law we refer to as the Rate Reform Law 22 MRS 3173J, which was enacted in August of 22. And so I won't read the entire slide, but basically this law enables us to set schedules for a regular rate review and adjustment, ensures that there's a review of relevant state and national data to inform rate amounts and payment models, formalizes a clear and transparent process of rate determination. It established a rate system subcommittee for Maine Care Advisory, and we also have a technical advisory panel group, which advises on technical matters and reviews an annual schedule. Next slide. Now, this slide is more specific to the CCBHC rate determination process and where we're going and where we've already been for this process. So for CCBHC specifically, we have already had some kickoff stakeholder meetings in the past, data collected with input from the CCBHCs. Today, we're having the public forum where we would discuss the rate methodologies. Also, we will be asking for official written comment period, which starts today and will end November 20th. And what will happen after the 20th is we will review those. We will respond in writing to these comments, and they will be posted on our rate reform website. And then the final step is final initial cohort CCBHC rates. So again, today we're doing the rate methodology presentation and then providing an opportunity to have that written comments back to us. I will hand it over to Toby.
That's right. All right. Thanks, Jess and Liz, for walking us through that, through a little bit of the background. At this point, we can get into what exactly is a PPS rate. So that's what we're going to talk through in the PPS rate background. All right, so the PPS rate has a couple of goals, and the goals are to provide a cost-based reimbursement that accounts for historical and anticipated costs to provide CCBHC services. So one thing I'd like to note is that when we say anticipated costs and historical costs refer to actual cost data, so actual experience from the reporting period. Anticipated costs are costs that the clinic determines are needed to support the implementation of the CCBHC model. So all of this is intended to create a rate that supports the implementation of CCBHC and the ramp up of services. Those anticipated costs will only be included in the initial demonstration year cost report. So the PPS rate is intended to sufficiently cover the total costs for provision of services and to provide financial predictability to providers. Also, the rate can be thought of as a complement, to the requisite practice transformation efforts needed to implement the CCBHC at the clinic. So the rate is really intended to cover all of the costs needed to support transitioning to the CCBHC model. So what exactly is a PPS rate? The CCBHC PPS rate is clinic specific, so there's no statewide PPS rate. Each clinic that enters Maine's demonstration program will receive a unique PPS rate. That rate is a Medicaid per encounter rate based on completed cost report that details the allowable program costs and the program encounters over the course of a reporting year. So when I referenced those historical costs earlier, those are a portion of the costs and visits included in the cost report from actual experience. So some of the details of the PPS rate that really make the PPS rate a PPS rate are that the PPS rate is calculated by dividing the total CCBHC costs, which are the allowed program costs, by the number of patient encounters. So this rate includes both Medicaid and non-Medicaid costs and encounters. The rate, however, is only paid out for each Medicaid encounter. So while the rate is calculated based on total costs and visits, the rate is only paid out for Medicaid beneficiaries. The PPS rate reflects the cost per visit, including indirect costs that have been allocated to CCBHC services. Now, the rate does not include direct non-CCBHC costs, which we'll talk later about how CCBHC costs and non-CCBHC costs are determined. But any program costs outside of the CCBHC model are not included in the rate. Indirect costs that are not allocable to CCBHC services and unallowable costs under CMS reporting principles are also excluded from the PPS rate. So only those direct CCBHC costs as well as allocated indirect costs are included in the PPS rate. The PPS rates are set by the state Medicaid agency, and the CCBHC PPS rate structure is very similar to the FQHC PPS rate structure. The FQHC rate structure is kind of a predecessor to the CCBHC reporting methodology and rate structure. So CMS originally outlined two CCBHC PPS options, a daily rate PPS1 and a monthly rate PPS2. However, in early 2024, CMS also issued updated CCBHC guidance, and that guidance included a foundation for two additional rate types to delineate crisis services. So there is a PPS3 rate, which is a daily rate with the inclusion of crisis services, and a PPS4 rate, which is a monthly rate with the inclusion of special crisis service rates. So there are four PPS rate types. For Maine's CCBHC demonstration, the state has elected to use the CCBHC PPS2 rate. So just to reiterate, that PPS2 rate is a clinic-specific monthly Medicaid per encounter rate. So a couple of key functions of that PPS2 rate are that the PPS2 rate is paid out once per month per qualifying Medicaid encounter. So regardless of the number of services provided to a Medicaid beneficiary in a month, those services are all reimbursed under one monthly payment. CMS requires that PPS2 states have a couple of mechanisms in the rate that are unique to the monthly rate. So an outlier threshold is required for the PPS2 rate. And that outlier threshold is basically just a charge level at which, when the charges exceed that designated level, they are determined to be an outlier at that point. And those costs are allocated to an outlier pool, which will be paid out, but essentially it's reserved for future payment. PPS2 states are also required to implement quality bonus payments, which are an additional payment above the basic PPS2 monthly rate. Those quality bonus payments are given to providers meeting certain CMS and state-defined quality and performance standards. What exactly are those thresholds is something that we'll cover later on in this presentation. We'll also talk about which standards are set by CMS and what standards the state has determined, as well as how clinics can achieve those quality bonus payments and standards. And PPS2 states also have the option to define special populations, which receive a population-specific PPS payment. So states may designate a population of interest, which may be a target population, a target condition, or a population that is known to have a higher cost than the general population. However, at this time, Maine has elected not to define special populations for the initial demonstration year. So the CCBHC PPS rate has a couple core services, 9 core services, which are required by CMS. So CCBHCs are required to provide these 9 core services, which can either be provided directly by the clinic or contracted with a designated collaborating organization, or a DCO, to be provided on behalf of the clinic. So CCBHCs and their DCOs may receive approval to provide additional services to meet community needs beyond those 9 core services. But essentially within those 9 core services, states have the latitude to determine what specific services are covered under the broad service categories. So each of these 9 service categories will contain individual services intended to meet that service requirement. We refer to the services under these 9 core services, under these 9 core service categories as the state scope of services. So CCBHCs must provide these services through the CCBHC or through a designated collaborating organization. And it's worth noting that the mobile crisis and crisis line costs, which we've highlighted on this slide, will not be included in the CCBHC as they are run through a separate state-sanctioned agreement. So that is kind of a program-specific, a main-specific piece of the program design here. So here we have an example of a state scope of services, which includes basically what types of encounters and what types of services are eligible for CCBHC reimbursement and trigger CCBHC encounters. Some of these services may be required or allowed. Required services would be a service that all CCBHCs are required to provide, and an allowed service would be a service that CCBHCs may provide in addition to the required services. So what we have is a description of the service, the applicable service codes and modifiers, the requirement to provide the service under the CCBHC model, and we also have over to the right the relevant section of the main care billing manual. So providers essentially use this scope of services to transition from their prior, fee-for-service delivery model to the CCBHC model and the PPS rate. The scope of services is used to determine, what services are provided to each provider's populations to deliver the full scope of the CCBHC service and the CCBHC model. These codes are also used to determine CCBHC allowable costs, to bill visits, and to develop the PPS rates. So now to get to the part you've all been waiting for, which is math. We have enough math where it's going to require 2 slides to walk through the calculation, but don't worry, the calculation is actually very, very simple. So what we're going to walk through is just how is the PPS rate calculated. So as I mentioned earlier, direct CCBHC program costs and allocated indirect costs equal the total CCBHC costs. So that is the total allowed cost for a CCBHC. Now that total CCBHC cost is divided by total charges. Charges are determined as the billed amount per unit in accordance with the relevant main care billing model or the relevant fee that is being developed for CCBHCs to bill. That gives you the cost to charge ratio. The cost to charge ratio is then multiplied by population charges to give you the total cost of CCBHC services for each population. Now, I know that earlier I said that Maine is not currently using special populations. So when I use the term population here, what I'm really talking about is outliers and non-outliers as populations. So earlier I mentioned the PPS2 rate has a requirement for an outlier threshold, and we have to either assign cost to the PPS rate or assign cost to an outlier pool, which is that reserved for future payment. So just to reiterate everything, the total expenses, the total CCBHC costs are the direct CCBHC costs plus the allocated indirect costs. Dividing the total CCBHC cost by total charges gives you the cost to charge ratio, which is then multiplied by each population's charges to determine what dollars are allocated to the PPS rate and what dollars are allocated to the outlier pool. So then to finalize the PPS2 rate calculation, that total cost of CCBHC services is divided by the total monthly visits. A monthly visit, again, regardless of the number of encounters that a beneficiary has in a given month, that is enumerated as a single visit per month. So taking the total cost of services divided by total unique patient monthly visits, we get the CCBHC cost per visit. And then the CCBHC cost per visit is multiplied by the Medicare Economic Index adjustment. The Medicare Economic Index, or MEI, is an inflationary market basket developed by CMS and is intended to trend costs from the reporting period, which is the historical or actual experience, to the rate period, which is the period in which the PPS rate is paid out. So to reiterate everything, essentially we're taking total costs divided by total visits to develop the base rate, and then trending that rate by the MEI to develop the cost per visit PPS rate. So a couple of key pieces of information here on the CCBHC PPS rate is that we have the CMS CCBHC cost report instructions and template linked here. The cost report instructions and template can be found on the CMS website, and the materials have been updated most recently in early 2024. The CCBHC cost report also has some general requirements for providers that provide a framework for cost reporting. And some of those general principles, which we'll cover in the following slides, but some of the general principles that provide that framework are that the cost report must be prepared on the accrual basis of accounting, so in alignment with generally accepted accounting principles. All requested information in the cost report template must be provided, including certification information, provider information, as well as cost and visit information. And all amounts in the cost report should be rounded to the nearest dollar. So what are the key pieces of guidance that govern the reporting of costs for the CCBHC model? Well, the CCBHC cost report and cost reporting process is actually governed by a couple titles in the Code of Federal Regulations, including 45 CFR Part 75, 42 CFR Part 413, and 2 CFR Part 200. These CFR titles, kind of broadly speaking, govern reporting of costs for federal grants and federal expenditures. So we have to follow that guidance when preparing the cost reports to ensure that, the spending of federal dollars is in alignment with the Code of Federal Regulations. CMS cost reporting principles are most broadly outlined in 45 CFR Part 75 as it relates to the CCBHC model, as this chapter applies to all Department of Health and Human Service grant and award recipients. Most commonly, we will reference Subpart E of this CFR title, which contains guidance on CMS cost reporting principles, including allocation of costs, direct and indirect costs, as well as treatment of specific items of cost. CCBHCs must adhere to these principles when reporting direct, indirect, and unallowable costs. So it is recommended that providers preparing cost reports really read and understand these sections of the Code of Federal Regulations to understand how to allocate costs, how to treat costs, especially specific items of costs, which may be unallowable in the CCBHC cost report. So there are a couple basic PPS rate concepts, and one of the basic concepts is that the total expenditures of a CCBHC and of an organization can be broken down into cost buckets. And the cost buckets include direct CCBHC costs, direct non-CCBHC costs, indirect costs, and unallowable costs. Going back to a concept that we touched on earlier, the PPS rate for CCBHCs only includes direct CCBHC costs and allocated indirect CCBHC costs. So direct CCBHC costs are costs for CCBHC services, as outlined in the state scope of services. So the cost to provide those services within the state scope are considered direct CCBHC costs. Those are costs that can directly be traced to the provision of services such as provider salary and wages. Indirect costs are typically considered overhead shared expenses that are allowed within the organization. So something we might think of as an indirect cost is rent, office salaries, human resources, accounting and finance, those functions that are shared between the CCBHC line of business and other lines of business. So to segue into the other lines of business, there are some direct costs which are not covered under the CCBHC model because the CCBHC model is narrowly a program to cover, outpatient behavioral health services. So an example of a direct non-CCBHC cost would be residential treatment. The costs of room and board, for example, are direct costs that would be excluded from the PPS rate, as those residential treatment services are outside of the scope of the CCBHC model. Unallowable costs are those costs that are not allowed under CMS cost reporting principles. Now, these costs may be direct or indirect. There are many examples we could use, but a common example is advertising costs, bad debt expense as well. Those are items that CMS has explicitly outlined in the Code of Federal Regulations cannot be reimbursed through the PPS rate. So how does the state go about developing PPS rates? Well, there's quite a process, as I'm sure some of you have experienced, including multiple steps, multiple layers of review, and various technical assistance. So as a broad overview, MaineCare and Mercer have engaged providers to develop the cost reports and PPS rates. This process has been ongoing for, I believe, over a year at this point. We've been working on technical assistance for cost report development. The key steps have been large group and individual technical assistance on cost reporting principles and documentation preparation. So this began with kind of a kickoff and orientation call with all the providers, the MaineCare team and Mercer, talking through the cost report, the underlying principles and documentation standards. There have also been synchronous large group technical assistance sessions on individual topics, key topics such as outliers. We've also held asynchronous technical assistance via email. So any questions that have come up, and also individual technical assistance through video calls. So there has been technical assistance that is available to individual providers as well as in a large group basis. Other steps in developing the PPS rate include joint review of provider CCBHC cost reports and documentation submissions. So that joint review includes review from Mercer and MaineCare. Key items reviewed include preparation of review documentation, providing feedback to CCBHC providers, again, asynchronously via email and through individual meetings, as well as discussion of issues with cost reports and observations in cost report submissions and topics of interest to each provider. There have also been policy analysis components that have been conducted on cost reporting topics and development of state-specific processes for cost reporting. So there have been some key pieces of documentation issued on specific cost reporting topics, as well as just kind of general guidance on cost reporting from the state. Cost reports were reviewed and developed in accordance with that CMS guidance, generally accepted accounting principles, the applicable Code of Federal Regulations, and state practices. So something that is very important to the state is the review of the cost reports. Again, we mentioned that there's been a joint level collaboration between Mercer and the state to review these cost reports. And the state has undertaken some specific tasks to ensure that the cost reports align with policy objectives, as well as to ensure parity between CCBHC providers and other behavioral health and primary health providers in the state. So a couple key components of the state review included cost classification, which is primarily ensuring that costs that are recorded as direct, indirect, administrative, and non-CCBHC costs have been appropriately treated. And the state may have reclassified those costs within provider cost reports as needed. Costs that also should be capitalized, but maybe in the initial cost reports were expensed, have been adjusted by the state to incur that cost over multiple years and are not expensed as a single year cost. And that is in accordance with generally accepted accounting principles. There have been some staffing and wage related review components within the state's review. So for incumbent providers, that is providers that have been on staff at the CCBHC in the reporting period, wages were not adjusted. So those wages were built into the PPS rates as incurred and submitted by the providers. So those incumbent wages include providers and staff that have wages above the State Bureau of Labor Statistics median, or the BLS. Now, treatment of vacant positions, and this treatment is only for the first year cost report because, as we touched on earlier, anticipated costs are only included in that initial cost report. So anticipated wages for currently vacant positions or new staff wages that required graduate level education were treated in the cost report as the lower of what the provider recorded, so the requested amount in the cost report, or the state's median wage. So essentially there's a cap on those graduate level education wages for anticipated positions. And that kind of wage level is determined by the state median wage per the Bureau of Labor Statistics. The anticipated wages for all other currently vacant positions are the lower of either the provider recorded amount, so the requested amount in the cost report, or 75% of the state's median wage per the Bureau of Labor Statistics. So the state reviewed the anticipated wages for all positions, direct staff, indirect staff, as well as those positions that require graduate level education and those positions that do not require graduate level education. And in accordance with best practices, determines the Bureau of Labor Statistics amount for those wages. So the main care standard approach is to use the state median wage values when setting rates. The CCBHC model is different from that kind of standard process in that it recognizes different wage benchmarks for incumbent staff versus vacant staff positions and those anticipated staff positions. The main care team is seeking to align the wages between providers and even between providers outside of the CCBHC model to the extent possible. And again, this goal is really to ensure that there's parity. So the proposal is intended to account for the nature of those vacant and anticipated positions being built into the PPS rate, recognizing that incumbent wages may be incurred above the median for that position, ensuring that or aligning with the 1 year rebase process, which I'll get into the rebasing process in the next few slides. But the main care team is essentially recognizing that, costs will be different for the initial demonstration year and costs will be rebased after a designated period of time, at which point the true costs for each position will be recognized. And another key item to recognize is that, there are hiring opportunities and differences between different positions within the CCBHCs And again, even between other providers in this state, there are differences in the hiring opportunities. So to kind of put a bow on the state's review and wage review process specifically, the state is recognizing that the CCBHC model does afford great opportunity to the prospective CCBHCs. And in the interest of aligning the state CCBHC model with state best practices for rate setting and state standards for rate setting, there have been a couple wage review standards implemented for this initial demonstration year. So getting into the rebasing, which I kind of teased on the last slide, but there are a couple CMS requirements for rate rebasing. One of these requirements is that demonstration providers must submit a cost report annually as a cost tracking measure. So for each demonstration year, each provider must submit a cost report. CMS also requires that the PPS rates be updated annually to ensure rates change with healthcare costs and the cost of inflation. So in the interest of covering the rebasing guidance from CMS, we'll cover a couple key points for the rebasing, which are that states are required by CMS to either annually update the PPS rate by trending with the Medicare Economic Index, which we referenced earlier, or by rebasing rates to actual cost and visit data from the CCBHC cost reports. So states have the option of annually using either the Medicare Economic Index to trend existing rates or to rebase rates to actual experience during the reporting period. Each demonstration year, the states must consistently use the same methodology to update rates across all demonstration CCBHCs within a cohort. So that annual PPS rate update for the initial demonstration CCBHCs, either all of those CCBHCs will have their rates trended by the Medicare Economic Index, or all those states will have their costs rebased to actual cost. Sorry, I think I said all the states will have their costs rebased. I meant to say all the providers will have their costs rebased to actual costs. When rebasing the rates to actual cost and visit data, an interim rate may be paid until final rates are developed. So I think that we've got a good graphic on the next slide that covers the rebasing timeline, and we can cover a little bit of how that interim rate will be used when looking at that timeline. Now, the interim payments do have to be reconciled to final rates, whether that's recoupment or additional payments. So the demonstration PPS rate is effective for an entire demonstration year. So any interim payments have to be reconciled. States must rebase initial PPS rates after the second demonstration year to reflect the ramp up of costs and visits and rates. And states must also rebase rates to actual costs and visits at least every 3 years from the last rebase. So these are new requirements from CMS intended to ensure that, anticipated costs aren't carried forward indefinitely. Rates are set prospectively and recoupment is not allowed. So rates cannot be updated mid-year or set retrospectively. The rates are set prospectively. And even if costs come in over or under the PPS rate, the rate is paid out as the rate was set. Kind of the one place I don't want there to be confusion is that the interim reconciliation is not the same as recoupment of a rate. All right, so that's kind of a fine technical detail that I wanted to point out, is that reconciliation to interim payments is actually in alignment with the setting of the rates prospectively. Those two bullets are not at odds with each other. And then finally, states are not allowed to rebase during a demonstration year. So rebase rates have to be effective for the entire demonstration year. So what will the PPS rate development and rebasing process look like for Maine? So as I mentioned earlier, CMS requires a rebase to actual costs after an initial experience period, and a rebase is required at least every 3 years thereafter. So before we get into the timeline, you'll see that a couple of the call out, boxes have the term actuals. When I say actuals, I'm referring to actual cost and visit experience from a reporting period. So again, before we get into the timeline, in non-rebasing years, rates will be trended by the CMS Medicare Economic Index. And even in those rebasing years, the interim rate will be set by trending the current rate by the Medicare Economic Index. So that's a requirement of CMS for demonstration states. So Maine plans to, for their rebasing timeline, rebase in demonstration year 2 or calendar year 2026 using experience or actual costs and actual visits from the initial demonstration year. Then in demonstration year 4, the state intends to rebase again using demonstration year 3 actual reporting period, costs and visits. I believe that rebasing in demonstration year 4 coincides with the renewal of CCBHC certification. So the intent is to recertify and rebase rates at the same point in time. And then beyond that rebasing in demonstration year 4, I believe the intent is to rebase with every recertification indefinitely. So that is why there's a 3-year gap between demonstration year 4 and demonstration year 7 in the rebasing. So this is the state's plan to rebase and the rebasing timeline that is currently laid out. Again, in those non-rebasing years, so demonstration year 3, demonstration year 5, demonstration year 6, the rate will be adjusted by the Medicare Economic Index. In demonstration year 2, demonstration year 4, and demonstration year 7, the rate will be rebased based on prior year actual experience. So a couple other items to cover, going back to the PPS2 rates unique structure, there are requirements of CMS has outlined of the PPS2 rate. One of those being that PPS2 states have to implement quality bonus payments. So MaineCare has determined selected quality measures for which providers may receive additional reimbursement, provided those quality thresholds are achieved. So a couple of key items on the background of quality bonus payments or QBPs. The CCBHC QBP pool will be equal to 1% of total annual PPS payments. So each provider, provided they meet the quality thresholds, will be eligible to receive an additional 1% of their total PPS payments on top of the total PPS payments. Maine will use 3 clinic-centric quality measures, time to services, depression remission at 6 months, and initiation and engagement of substance use treatment, which is a quality gateway for providers to receive any quality bonus payment. So if the performance thresholds for those 3 measures are met or exceeded, the provider will receive 40% of the total eligible quality bonus payment pool. Now, the remaining 4 quality measures selected, the providers can earn up to 15% of the total quality bonus payment pool per measure where the threshold is met or exceeded. So the providers are eligible for the quality bonus payment of a particular measure if the eligible population for the given measure, and I think we've got a good example of this on the next slide, exactly how the math works out. But essentially, there needs to be a certain number of individuals within the population for an eligible population to be able to receive the quality bonus payment for the selected measure. And if the CCBHC does not have that minimum number of required individuals in that population, the QBP eligibility will be redistributed towards the other clinic-centric measures. So I think that's a kind of a fine point of the QBP methodology, but essentially there has to be a certain number of individuals within that population to be able to receive the quality bonus payment for that specific measure. Otherwise, the QBP pool is kind of reallocated towards the other measures. Now, CCBHC also has to be enrolled as a CCBHC for the entire demonstration year, and the data must be reported to Maine DHHS within 6 months following the end of that demonstration year to be able to receive the quality bonus payments. If those thresholds are met, the quality bonus payments will be made in a lump sum payment within 12 months following the end of that performance year, after all the final data needed to calculate the QBP is received. So while that was a lot of very fine and technical points of the QBP development and methodology, we have tables of the quality bonus payment measures for the clinic-centric measures. So you can see here the time to services, depression remission at 6 months, and the initiation and engagement of substance use disorder treatment have specific age group criteria, threshold values that must be met, and data sources to determine if the threshold is met. And when all 3 of those thresholds are met or exceeded, 40% of the QBP pool will be remitted as a quality bonus payment. Now, the additional QBP measures may be achieved, one by one. So you don't have to meet all 4 to achieve the additional 60% of the QBP pool payment. Each measure, achieving each measure will result in 15% of the QBP pool being remitted. So I think that these are good slides to or good tables to kind of visualize and take forward for the provision of services and track those thresholds in the data source to be able to see, how the QBP pool will be paid out for each organization. So another unique characteristic of the PPS2 rate is that CMS requires an outlier threshold and outlier payments be made for PPS2 providers in PPS2 states. So as a process, outlier payments will be made to providers on a periodic basis, no less than annually. The incentives of the outlier threshold are to provide a higher quality of care to prevent, unnecessary and additional visits within the same month. The outlier threshold may also place providers at a risk of loss when faced with high acuity. However, that outlier pool is also intended to, set aside those reserves for future payment, which kind of, protects the providers there as well. So there is kind of an upside and a downside to that outlier payment. But really the key there is that it incentivizes, more efficient and higher quality care. So in determining the outlier threshold, the state considered what levels of risk should the clinics face and what risk should they bear in providing those monthly services, and how common should exceeding the outlier threshold be? So essentially, what is the typical incurrence? What do we expect that to be for outliers? So MaineCare and Mercer conducted a joint analysis of actual claims experience to evaluate potential outlier thresholds and the monthly claim amounts exceeding those thresholds. And in reviewing that analysis, what we determined is that roughly 3% of monthly claims would exceed an outlier threshold of $2,000. So the state has set the outlier threshold for CCBHC monthly visits at $2,000. Any amount of charges above $2,000 in a given patient month will be set aside for that outlier pool and reserved for that outlier payment. So that is the function of the outlier threshold and how the MaineCare team in Mercer reviewed that claims analysis to develop the outlier threshold in a way that both, incentivizes that efficient care and measures the risk of, high acuity patient months and those other considerations that we have to think through when determining an outlier threshold. Well, at this point, we are at the end of our, technical cost reporting and programmatic discussion for today. At this point, we can take questions. Before we get into the Q&A, I did promise you all at the beginning of today's conversation that I would discuss how to submit official comments. So official comments do need to be submitted in writing to DHHS after the meeting. Again, any Q&A items in today's call are not considered official comments. Official comments have to be submitted to DHSS by November 20th, 2024, so 2 weeks after today's call. While the official comment period is open now, the meeting does not, any questions in here are not a public comment. The public comments to be official have to be submitted to ratereform.oms@maine.gov. So make sure if you have a question that you ask in today's Q&A that you would like to be submitted as an official comment, it must also be submitted to the Rate Reform mailbox, as today's meeting is not, the appropriate venue for official comments. However, at this time, we are able to open up the Q&A to talk through any questions that may have arisen during today's discussion.
Great, thank you, Toby. John, as the host, are we able to allow, I'm not sure how we're going to allow people to unmute to be able to ask their questions out loud. I know that people are leveraging the Q&A effectively, but is there another way to get people to be able to ask their questions out loud?
Yeah, if anybody does want to ask their questions, can you just raise your hand and then I can unmute you? Yep. So I see Dale. Dale is first, so I'll go ahead and unmute him first. All right, Dale, you should be live now.
All right. Can you hear me all right?
Yep.
Great. So I put a convoluted question in the Q&A, but it's probably because I don't understand it well enough. Just in terms, can you speak a little bit more about how wages are being managed? I'm particularly interested in terms of every provider has a different array of services. Obviously, we all deliver the required, but then there are services that go beyond that, which might generate a different type of wage. And I just didn't quite understand the adjustments that you were talking about. Thank you.
So I will defer to the state here, although my understanding of the adjustment to the 75th percentile of the median wage, which refers to those anticipated positions which do not require graduate level education. So my understanding of adjustment to the 75th percentile of wages, and Dale, in the context of the question, is that there are some services that may require, a more experienced professional to provide, which may demand a higher wage. My understanding of the state's use of the 75th percentile of the BLS wage is that it is intended to account for that scenario where you may have some providers that are more experienced and can provide those services that require a higher level of experience and education to provide, while there are also providers potentially in the same staff position that you may be able to hire at the entry level, for example, to provide, less intense services, or to provide those services that do not require as much experience. So the 75th percentile level is intended to, provide a harbor, or basically just like that threshold, right, where There may be some providers above that level and some providers below that level. And the intent of the 75th percentile is to make sure that you are able to hire those providers with that additional experience, as well as to ensure that, you know, the CCBHCs aren't basically overpaying providers and taking providers away from the employment pool for other providers in this state. So my understanding is that essentially we have to ensure that there's parity and that CCBHCs don't have like a monopoly on hiring the most experienced providers within the state. But I will defer to the state there to see if there's any further thoughts on that question.
Sure, I can jump in. Thanks for the questions. And so this is really a proposal to account for the fact that that CCBHC is different in how rates are set and delivered. In addition to what Toby said, which is also accurate, but that there is a distinction being drawn here in the proposal from people who you already have on staff, the incumbents, and then the anticipated costs that get built into the PPS rate day one for the first year for those staff positions that are vacant. So trying to balance the amount of costs that are built into a monthly rate for vacant positions on day one, and then as Toby said, to differentiate that there are staff positions where we're proposing that you may be able to hire at a more entry level than other staff positions where the standard, as you all are aware, main care process, the graduate level, and for all of the rate studies where this isn't a distinction that is made, we always benchmark at the median. One thing I'll say too is that this is also, as the justification in the bottom part of the page, is recognizing that there's a rebasing process at year one, so that all of this gets updated to reflect what did you actually hire as and for successfully during the first year, and that other states have experienced that oftentimes the anticipated costs or the year one anticipated costs are higher than what happens after a rebasing. So we're trying to make sure that we're not overpaying in the first year and balancing that with how main care normally sets rates. All that to say, understand the feedback, wanted the feedback on this proposal, and I would encourage you when you submit comments to also propose alternatives as opposed to just asking questions. It's helpful if you say, you know, if you have any thoughts of, okay, I can see where you're coming from, how about this instead? Or anything like that. It's always helpful for us to have more specific feedback on this kind of decision.
John, I think you saw that there were some other hands up. Okay, we'll go to the next question.
Yep, we've got Dale, Ben, and Josie. Dale, did you want to add your follow-up?
Yeah, just and I'm not looking for a response. I just wanted to, because it's unique, it may be unique to us, but we were asked to move some existing positions into the anticipated column. These were positions that were funded under our CCBHC grant. So they have existing wages, and it may not be an issue going forward, but I just wanted to throw that out there that could become problematic if they're adjusted down because there are actually existing positions, but we had to move them into anticipated. So again, not looking for a response. I just wanted to kind of just put that out there.
Thank you, Dale. Let's move to Ben Strick. I'm going to unmute you. All right, Ben, can you hear me?
Thank you. I just wanted to clarify one part. So it is 75% of the median. It's not 75% of the maximum wage. So it's actually lower than the median wage.
No, sorry, I just clarified that in an answer in the Q&A to Ginny. It is the 75th percentile wage for the position, not 75% of the median wage. So
no, sorry, Toby, that's not correct.
Oh,
I don't think.
my bad.
Liz, that's not correct, right? It
Right,
is
it's correct
75%.
on the slide. It's
Yeah.
so the bullet of the treatment of vacant positions, the second bullet is correctly written in the way that we would want to interpret it. So 75th% of the state's median wage per
So
the
below the median, Ben, you're right. It's below the
Right.
median for those vacant non-graduate level
Positions.
positions. Yeah.
Non-graduate level. So graduate level clinicians, as an example, are, because what I'm seeing on the slide here, that required graduate level education or lower, is below the 75th, or is we're
The
allowed to
median.
hire? Okay.
Yeah, so graduate
Um,
level staff are built into the cost reports at whatever level the provider requested up to the state median. So some providers may have requested, we anticipate hiring a graduate level clinician at below the median, and we would say, okay, then we'll build that in. But if they requested to hire anticipated position above the median, we would have capped it at the median for that graduate level person.
Okay, thank you.
Hey, John, I
Okay,
think yeah,
we
sorry.
did have Josie, who had her hand raised, but I'm not seeing it raised anymore. Let me see if I can unmute her. Oh, yep, there she is. Thank you. All right, Josie, go ahead.
Can you hear me?
Yep.
Okay, sorry about that. So when you say 75% of the state's median, does the state's median equal the BLS median, which is 2 years old?
So I'll
does.
look to the state there. It sounds like yes.
Yeah, I was gonna say, that's correct, but Toby, I was hoping you could speak to the fact that like there's two levels of MEI, the way that these costs are adjusted forward might be helpful to explain here.
Yeah, that's correct. So there is Medicare Economic Index applied to the initial cost report rates.
Okay.
So the reporting period for most providers, I believe, was calendar year 2023. So 2 years of Medicare Economic Index trend has been applied to the total cost report costs.
And what are those trends, Toby?
We can,
Years? Yeah.
off the top of my head, I don't recall, but I believe it's around 6%. I think 4 to 8% would be the 2-year MEI trend from 2023 to 2025.
In total, okay, so
Yep.
3 to 4%, or 2 to 4% per year.
Correct. Yep.
Compound.
The MEI typically ranges from about 2 to 4% per year.
And is that compounded?
I believe that it is inherently compounded in the market basket that is published by CMS.
Okay.
So I
So,
believe that is accounted for.
all right, sorry, I was just reacting to the answer to Dale's question. So my question was regarding the rebasing. If rebasing is happening in year one, or based on year one costs, as you're showing here, and obviously most of us are going to be in major ramp up mode for that first year, is anticipated cost still part of the calculations for the rebasing?
That's a great question. Anticipated costs are only included for the initial demonstration year, so you'll only have those costs reflected in demonstration year 1.
Mhm.
However, it is the intent of CMS and of Mercer and Main Care to ensure that less than complete cost data is annualized. So if you hire a provider for a service on July 1st, 2025, you'll only have 6 months of cost and visit experience. However, we will annualize that to make sure that you have a full year of experience in the rate. So while that's not an anticipated cost, we do make sure that less than complete year of experience is annualized to make sure that you're fully compensated for that position in the next year.
That's helpful. What about those positions which are not hired by the end of year one? My guess is that may be possible, right?
If a position is unfilled at the end of the initial demonstration year, that cost will not be reflected in the upcoming rebased cost because we have no cost experience for that position and there will not be an anticipated cost due to the nature of the rebasing.
Okay.
So I think that, these are great questions, and I think that the main team's proposal for rebasing, as we see, offers 2 rebases within the first 4 demonstration years, which really should give a great opportunity to incur those costs and have those rates rebased to actual cost to reflect that experience twice within those 4 years.
So if the rebasing happens, just a follow-up question, I'm sorry. Rebasing happens during year 2, for year 2?
Correct. The
What
rebate rate will be effective for the entire year of demonstration year 2, based on demonstration year 1 costs. As we talked about earlier in the call, there will be an interim rate paid, which will be demonstration year 1's rate trended by the Medicare Economic Index until rates are finalized for demonstration year 2, at which point all payments will be that have already been made will be reconciled to that rebased rate.
Okay, thank you.
Okay, we've got several questions up. Now I'm going to go in order. Looks like Ben, you have your hand up again. Is that correct? I'm going to unmute you.
No, I just didn't see that it was still up. My apologies.
Got it. Okay, no problem. Let's go with Adam. I'm going to allow you to talk. Go ahead.
Thank you so much. Can you hear me?
Yep.
Wonderful. Thank you. I appreciate the time and intentionality going into this presentation. One question I had, just again, in terms of the rate methodology with the cap on anticipated positions, did the state, have any consideration or calculation in terms of, how many positions may go unfilled or the inability of some providers to fill these positions with regards to, the sort of downstream impact on ability to actually provide many of the services in the model? I think there's concern, especially as you noted, if these are not filled after year 1, they won't be considered going forward. That, these are not just positions, they're folks providing services. And especially, where we're looking at a workforce crisis right now, I think there was a lot of hope that this model would be able to alleviate some of that and guarantee that these services and access can happen. So I'm just curious if there's any sort of calculation or consideration in terms of what the impact of unfilled positions would be under this methodology. Thank you.
Yeah, thanks so much, Adam. I think, well, I think one of our, there's not some per se exact calculation on unfilled positions for like in terms of like a quantitative calculation. We're still looking at this, the different staff, the different types of staff, the service they provide across providers, filled, unfilled, all of the different parameters here, and trying to put forward a standard methodology as a proposal for you all today. So our hope is that you all can give us some information back that will help us evaluate this proposal. So if there is, it sounds like maybe if there are concerns that this could result in a whole year of being unable to fill a position, we want to hear about that. Which positions are you most concerned about? Do you have an alternative proposal? I see Ginny put, some alternative thoughts in the chat. Like those are all helpful things as for us to have some more information from you all on as we think about what can we do from the department to balance being able to put forward a fiscally responsible model that's standard for all providers and will give us a basis for going forward with this program into longevity, but also meets the needs of the program. So that's what we're trying to balance here. We're trying to balance how this program is different and unique on purpose from other main care models, and that's why there's this distinction between incumbent and vacant positions. There's this rebasing, which is different. So we're trying to balance all those things into something that can make sense. So we really just appreciate you all giving us more information after the call today about what specific areas, positions, services you think will be most impacted by something like this. And then again, alternative solutions if that's where you're headed.
Dale, go ahead. I think you raised your hand.
Yes, thank you. So just, it's kind of related to that question. So I certainly understand the concern in terms of wages and not having a differential between a clinician in a CCBHC versus a clinician providing outpatient in a clinic or outside of the CCBHC. However, there are different requirements associated with those services. So with the CCBHC, the nature of the requirements to deliver CCBHC is the commitment to serve everyone within a certain time frame, not put people on wait lists. That can only be accomplished with our ability to recruit, which is what, when we established our cost reports, looking at where we needed to be competitive to recruit. So the difference in terms of the requirements should drive the costs for those positions. They're not the same thing. And if we're, as a state, going to look at a clinician and what they get reimbursed and try to level the playing field, the CCBHC is going to be difficult to get up and operationalize it and keep it staffed the way that it needs to be.
Yeah, understood, Dale. I think going back to Olivia's last comment there, I think that's a great addition to the official written comments. Just good feedback for the state to have. So I think that's something that I'd encourage you to submit to the rate reform mailbox. Your thoughts laid out on that topic to ensure that gets to the rate team and is considered.
Dale, go ahead.
I'm sorry, just one quick follow-up. Toby, in terms of other states and looking at this, do you have any data in terms of the wage impact and changes as a result of transitioning to CCBHC? Is there any benchmarking data?
I think that the most helpful information here, and granted, I cannot point you to like a specific resource. I just don't know off the top of my head. But I believe that the ASPE reports may have some of that information. So I would recommend that's ASPE. They issue an annual report on the impact of CCBHC clinically, financially. So I would recommend reviewing the ASPE reports on the CCBHC demonstration years. That information may be contained in one of those reports.
Ben, go ahead, please.
I, in the question and answer, posted a link to what looks like the BLS wage scale. Would it be possible to clarify whether that is the wage scale that was used by the state or not? If it is, it looks like the median wage is well below prevailing wage in our area. And I'll be curious if that is accurate or not. The other question would be, is a similar methodology used for setting wages in FQHCs? And what has the impact been there?
So I can defer to the state on the BLS data used. As far as FQHC experience that I've had anecdotally, we have seen capping of certain position wages at a level of the BLS median. I think that I'm not sure if we have any, long-term data on that from the state that I'm thinking of. But it is possible that there have been, like I mentioned, wage studies or reports on FQHCs that have been conducted by, third parties, FQHC provider associations, for example. So I'd recommend doing like a Google search for those and seeing what information is out there, because I'm not entirely sure for FQHCs, but the FQHC program has been around for much longer than the CCBHC model. So I think that there would probably be some longer term wage studies for FQHCs, and you may be able to find that information, but off the top of my head, I'm not familiar.
And Ben, we can take that back to answer on a main care specific level, how we treat the different providers. These are not, although they are similar, there's differences. And one of the things that's different is the rebasing after year one. And also the process by which anticipated costs are built into PPS rates. So while the two models are both PPS rates and they both have an MEI applied in years that are not rebased, they're not exactly the same. And some of those nuances are potentially contributing to some of the differences. But the rate setting team, I'm not going to put them on the spot to explain exactly how they do FQHC cost report analysis, but that's a great question, and we'll get back to you.
Thank you.
Dale, did you have a follow-up?
Oh, no, I
Oh,
didn't know my hand
okay.
was still up.
Yep, no worries.
Oh, sorry. And then I am going to put the rate setting team on the spot, though, to let us know somehow if that's the right link to the BLS. If that's possible to give the folks an answer to that while we're still on the call, that would be great. But we can keep going. So they'll do that via chat.
Okay. I am not seeing any other hands raised at this time.
We have some chat questions or Q&A. Liz, could you try to help with that, getting the BLS link confirmed while I try to go through some of the...
Yep, I'm working on that right now.
Okay, thanks. Some of these are related to previous topics. And again, we do want all comments submitted in writing too. When will this be posted? Jessica, Jess, are you able to answer that question? Or maybe it's already live. When is this going to be posted in the comment period deadline?
So normally, I did just post the answer, but we normally do post the recording and a copy of the PowerPoint presentation within 24, usually no more than 48 hours. Of the presentation itself, it's posted on the rate reform website, which I did put that in the answer, and it's also posted in our chat. So you can go there, but there will also be a notice that will be sent out that will have a link to both the presentation and the recording as well. So you can keep checking the website within, the next day to see if it's there even before you receive the official notice with the links in it.
All right, I see an open question about how the wage caps developed for Maine compared to other CCBHC states. And I will say one other place where we have seen some wage caps developed is specifically some states have been interested in capping management salary increases to a certain percent of the BLS. So that is something that we have seen in other states where there's been a determination that the wage should be capped at, you know, the median or the 75th percentile, for example, of the BLS median. This is something I've also seen in FQHC states as well. So there is precedent for, you know, use of a wage cap in specific areas of interest, I think, for certain positions. And I think that, again, I'm not sure if this information would be widely available online, but you may be able to find some information on FQHC like state specific FQHC wage caps or something similar.
I would probably, yeah, if that existed, Toby, I would probably think under, you know, primary care associations or the National Association of Community Health Centers, even maybe Feldsman Tucker. But yeah, as Olivia alluded to, which I think is a great point, it is not apples to apples. So I would definitely caution, you know, equating those two kind of in totality.
Sorry, everyone, I got kicked off for a second, so I apologize if I just left abruptly and you were talking to me at all.
All right, looks like the outstanding questions in the Q&A at this point are largely related to the wage cap question. Given that we are about a minute out from the end of today's webinar, I'd like to navigate back to the public comment availability. So public comment is open until November 20th. Again, that's 2 weeks from today. It looks like the recording should be made available within 24 hours of the presentation. So thank you to the Maine Care team for taking care of that. Make sure that you submit your comments again in writing to the rate reform mailbox listed below. You know, your thoughts are definitely valuable input here in determining the path of the CCBHC model in Maine, and we certainly value that input in the decision-making process. So thank you all today for your participation and for your questions. We look forward to seeing your comments to the rate reform mailbox and taking a look at those and discussing those further. To our Maine Care team, are there any closing thoughts that you all would like to cover before we end today's call?
I think just thank you, and you know, thanks for being here and this morning, and we're looking, you know, we always appreciate your time and being with you all, and especially this morning. So thank you all for being here.
Yeah, agreed. And don't hesitate to send all questions to the rate reform email inbox. You can also use, like, as questions come up, if they come to the CCBHC inbox or ours, we will forward them over just to make sure that we have the record. If you're confused about this whole process, don't hesitate to reach out to the contacts that you have related to CCBHC. We're happy to help filter where they need to go. Great. Thank you. Thank you to the Mercer team for pulling this all together and sharing the content today.
Absolutely.